Neurogenic bladder, lower motor neuron lesions at the level of the reflex arc, sensory atonic, motor atonic, and autonomic bladder. Sensory atonic bladder, lesion in the afferent sensory fibers, leading to absence of sense of fullness of the bladder with retention of urine with overflow. Motor atonic bladder, lesion in the efferent motor fibers, preservation of the sense of fullness, retention of urine due to inability to evacuate bladder voluntarily, castration is needed. Autonomic bladder, lesion in spinal center S2-3-4 in both afferent and efferent fibers, involuntary and incomplete evacuation of the bladder. Evacuation of the bladder occurs by its myogenic contraction. Upper motor neuron lesion, lesions above the level of the reflex arc, acute, retention of urine with overflow, gradual, partial lesion, perceptancy of micturition, complete lesion, automatic bladder, complete evacuation of the bladder. Evacuation of the bladder occurs by the spinal reflex arc. Lesions should be bilateral for any disturbance in bladder function to occur. Paraplegia, definition, paralysis or paresis of both lower limbs. Types, spastic paraplegia and flaccid paraplegia. Spastic paraplegia due to upper motor neuron lesion, any lesion in the pyramidal pathway. Flaccid paraplegia due to lower motor neuron lesion, any lesion from the anterior horn cells to the muscles. Spastic paraplegia, definition, paralysis or paresis of both lower limbs due to bilateral pyramidal tract affection. Types, spinal, cerebral, spinal paraplegia, focal, systemic, disseminated, this is the most common type, cerebral paraplegia, the least common type, causes in the parasagittal region and causes in the brainstem. Causes in the brainstem, syringobulbia, midline brainstem tumors, causes in the parasagittal region, traumatic vascular, inflammatory, neoplastic and degenerative cerebral palsy, neoplastic parasagittal meningioma, inflammatory encephalitis, meningioencephalitis, vascular, superior sagittal sinus thrombosis, traumatic, depressed fracture of the skull with subdural hematoma. Causes of spastic paraplegia. For focal paraplegia, we have vascular, inflammatory, and compression, vascular, anterior spinal artery occlusion, inflammatory, transverse myelitis, compression, acute, subacute, and chronic, glioma and ependymoma, neoplastic, syringomyelia, cavitary, spondylosis, degenerative, acute, TB of the spine, Pott's disease, inflammatory, fracture or fracture dislocation of the vertebrae with disc prolapse, traumatic, subacute, extramedullary or intramedullary. TB of the spine, Pott's disease, inflammatory, and tumors of the spine, neoplastic. Tumors that compress the spinal cord are divided into extramedullary tumors and intramedullary tumor. Intramedullary, inside the spinal cord parenchyma itself, glioma or ependymoma. Extramedullary, outside the spinal cord affecting vertebrae, meninges and roots. Vertebrae, extradural, primary osteosarcoma or secondary deposits. Meninges, dural, meningioma, roots, intradural neurofibroma. Then we have systemic paraplegia, systemic diseases affecting one or more systems selectively, usually bilateral and symmetrical, affecting pyramidal tracts either alone or with other tracts leading to paraplegia. Divided into heredofamiliar, secondary, and idiopathic. Idiopathic motor neuron disease, secondary, bilateral lateral sclerosis, subacute combined degeneration, heredofamiliar, hereditary spastic paraplegia, and hereditary ataxia, like Friedreich's ataxia and Marie's ataxia. Disseminated paraplegia due to disseminated disease of multifocal disease of the same nature, dis and dem, dis disseminated sclerosis, dem disseminated encephalomyelitis. Diagnosis of spastic paraplegia, clinical diagnosis, criteria to diagnose spastic paraplegia, we have paralysis or paresis of both lower limbs, hypertonia, hyperreflexia, positive Babinski sign, sphincteric troubles, especially perceptancy of micturition. Anatomical diagnosis, is it systemic, disseminated, or focal? And we have a clinical picture of the focal. To differentiate between systemic, disseminated, and focal: systemic, gradual onset, progressive course, affection, symmetrical affection; disseminated, acute onset, course, remissions with exacerbations, affection, multiple nervous system affection; and systemic and disseminated, we have no level, while the focal paraplegia with a level. Below the level, upper motor neuron manifestations and sensory loss. At the level, lower motor neuron manifestations with radicular manifestations. Clinical picture of the focal paraplegia: we have vertebral manifestations, radicular manifestations, cord manifestations. Vertebral manifestations and vertebral causes only, localized pain, tenderness, swelling, and deformity. Radicular manifestations and extramedullary causes only. We have posterior root affection, anterior root affection. Anterior root affection, localized lower motor neuron weakness in the muscles supplied by the affected root. Posterior root affection, early girdle pain, back pain referred to the distribution of the affected root. Late sensory loss in the dermatome supplied by the affected root. And then we have cord manifestation. Divided into sensory, motor, sphincteric affection. Sensory affection. For extramedullary lesions, we have for the sensory level, below which all types of sensations are diminished, and sacral affection, early loss of sensations in the saddle area, S3, 4, and 5. Intramedullary lesions, jacket sensory loss of dissociated nature, lost pain and temperature, preserved touch and deep sensation, sacral spare, preserved sensations in the saddle area, S3, 4, and 5. Motor affection, upper motor neuron lesion, below the level of the lesion due to affection of the descending pyramidal tracts, lower motor neuron lesion with fasciculation at the level of the lesion due to affection of the anterior horn cells, sphincteric affection, early in intramedullary and late in extramedullary, acute lesions, retention with overflow, gradual lesions, perceptancy if partial, then automatic bladder if complete lesions. Then we're going to compare between extramedullary and intramedullary paraplegia, and we are going to discuss it at the end of the chapter. Diagnosis of the stage of flaccid paralysis and stage of spastic paralysis. Stage of flaccid paralysis, shock stage. It occurs in acute lesions lasting from 2 to 6 weeks, characterized by hypotonia, hyperreflexia, no plantar response, paralysis of both lower limbs, retention of urine with overflow. Stage of spastic paralysis, established paraplegia. It occurs in acute lesions, recovery, and gradual lesions from the start. It passes into 2 stages, paraplegia in extension and paraplegia in flexion. Paraplegia in extension, it occurs in incomplete injury of the spinal cord. There is affection of the pyramidal tract with sparing of the extrapyramidal tracts, characterized by deep reflexes, exaggerated presence of clonus, hypertonia affecting extensors more than flexors, perceptancy of micturition. Paraplegia in flexion, it occurs in complete transection of the spinal cord, where there is affection of both pyramidal and extrapyramidal tracts, characterized by hypertonia, spasticity affecting flexors more than extensors, deep reflexes, less exaggerated, no clonus, automatic bladder, positive mass reflex. Any stimulus below the level of the lesion leads to withdrawal of the legs, sweating, defecation, ejaculation, and micturition. And finally, we have etiological diagnosis, the differential diagnosis of the causes, investigations, CSF, CT, MRI, plain X-ray of the spine, myelography, radio-opaque substance injected into the subarachnoid space, and then X-ray pictures are taken. For extramedullary compression, complete block with short tail, saddle-shaped. For intramedullary compression, increased width of the cord with long tails, fusiform shaped. Plain X-ray of the spine and vertebral causes only, destruction of the vertebrae, POTS, disease, trauma, tumors, narrowing of the intervertebral spaces plus or minus osteophytes. It occurs in spondylosis and acute disc prolapse. CT and MRI, accurate in localization of the lesion. And finally, we have the CSF. CSF functions normally, shock absorption, nutrition, and waste disposal. It passes from the ventricles through the lateral medial foramen of the fourth ventricle to the subarachnoid space covering the brain and spinal cord to be finally absorbed into the blood by the internal jugular veins, and they pass through the arachnoid villi, which are one-way villi. So CSF needs high CSF pressure than the venous pressure in order to pass from the brain into the bloodstream. CSF pressure measured by tapping of the CSF in the lumbar region using a needle connected to spinal manometer. Normally it's from 120 to 140 millimeter water. In extramedullary compression, it's markedly diminished, while in intramedullary compression, moderately diminished. Then we have CSF contents. Intramedullary compression, no significant change, while in extramedullary compression we have something called Freund's syndrome, characterized by spontaneous coagulation, cytoalbuminous dissociation, increased proteins but near normal cell count, and vansochromia, yellowish discoloration. And then we have Quickenstein's test. I'm not sure about the pronunciation. Bilateral jugular vein compression normally decreases the flow of the CSF from the subarachnoid space to the blood, leading to rapid rise of the CSF pressure in the manometer. In extramedullary compression, there is complete dynamic block, no change in the CSF pressure due to complete obstruction of the subarachnoid space, while in intramedullary compression, there is incomplete obstruction leading to partial dynamic block. So we're going to compare between extramedullary and intramedullary lesions. Regarding onset and sphincteric affection, extra painful with late or absent sphincteric affection, intra painless with early sphincteric affection. Clinical picture, sensory level in the extramedullary, below which all types of sensations are diminished, with early loss of sensations in the saddle area, while in intramedullary, jacket sensory loss of dissociated nature and sacral spare. Sphincteric affection, we've mentioned it. Investigations, CSF, and the extra, marked decrease in the pressure, complete dynamic block, Freund syndrome, while in intramedullary lesion, moderate decrease in pressure, partial dynamic block, no Freund syndrome. CT and MRI are diagnostic for both. Plain X-ray for extramedullary possible vertebral lesions, myelography saddle-shaped block, while in intramedullary, normal plain X-ray and fusiform-shaped block in myelography. Treatment, general care, physiotherapy, specific treatment of the cause such as anti-TB drugs for POTS disease. General care, care of skin, nutrition, fluid balance, care of the bladder, care of bowel by enema, care of bladder by castorization, antiseptics, parasympathomimetics in cases of retention, care of nutrition and fluid balance, tube feeding and IV fluids, care of the skin, frequent change of the patient's position and frequent washing of the back with alcohol zen powder. Special forms of paraplegia, transverse myelitis, acute inflammation affecting gray and white matter in one or more adjacent spinal cord segments, commonly in the thoracic segments. Etiology, idiopathic infection, immunological, iatrogenic and toxic, demyelinating this and them, iatrogenic and toxic, post-lumbar and IV heroin, immunological, following vaccination and associated with vasculitis, SLE, infections, bacterial, TB, syphilis, diphtheria, viral, herpes simplex, herpes zoster, cytomegalovirus, Epstein-Barr virus, influenza, Coxsackie B or ecovirus. Clinical picture, shock stage, 2 to 6 weeks, paraplegia, flaccid paraplegia, plus sensory loss, sensory level below which all types of sensations are lost, sphincteric, retention of urine with overflow, recovery stage, spastic paraplegia, plus sensory level below which all types of sensations are lost, sphincteric, precipitancy of micturition, differential diagnosis of transverse myelitis, anterior spinal artery occlusion, acute cord compression, and Guillain-Barré syndrome. Investigations, MRI to exclude acute cord compression, CSF examination, increased both cells and proteins, and in the disseminated sclerosis we have high immunoglobulin level. Treatment, non-specific symptomatic treatment, corticosteroids, ACTH intramuscular in disseminated sclerosis, prednisone 1 mg per kilo per day orally in idiopathic cases, SLE and disseminated sclerosis, anterior spinal artery occlusion, etiology, thrombosis, embolism, clinical picture, same to transverse myelitis, but there's sparing of the deep sensations because posterior columns of the spinal cord are supplied by the posterior spinal artery. Syringomyelia, definition, chronic disorder characterized by long cavities surrounded by gliosis in the central part of the gray matter of the spinal cord, most commonly lower cervical, upper thoracic, less commonly in the lumbar segments, and may extend up to medulla syringobulbia. Etiology, congenital and idiopathic. Clinical picture, commonly between 15 and 35 years old, onset and course, gradual onset, slowly progressive course. Cervical syringomyelia and lumbar syringomyelia. Lumbar syringomyelia, picture of epiconus lesions that we're going to discuss later. Cervical syringomyelia, motor manifestations, sensory, autonomic, and associated skeletal anomalies. Associated skeletal anomalies, pes cavus, spina bifida. Autonomic manifestations, Morvan's syndrome, Horner's syndrome. Sensory manifestation, jacket sensory loss of dissociated nature. Motor manifestations, early in the upper limb, localized lower motor neuron weakness plus fasciculations due to encroachment on anterior horn cells. Late in the lower limb, spastic paraplegia, upper motor neuron lesion due to encroachment on the pyramidal tracts. Investigations, MRI and myelography. Treatment, X-ray irradiation of the affected region of the cord. Physiotherapy and symptomatic treatment. Syringobulbia, it's a lesion of the medulla similar to the syringomyelia. The lesion starts in the medulla or may be upward extension for cervical syringomyelia. It involves the spinal nucleus of the fifth cranial nerve, bulbar nuclei, and vestibular nucleus. Pain in the face, followed by loss of sensation of dissociated nature, vertigo, and bulbar symptoms with loss of palatal and pharyngeal reflexes, with wasting of the tongue. Cauda Equina. During intrauterine life, the rate of growth of the vertebral column is faster than the rate of growth of the spinal cord. So normally the spinal cord ends in the junction between L1 and L2 vertebrae. So from this level downwards, the spinal cord is not empty, but it's occupied by a collection of lumbosacral roots known as a Cauda Equina. Cauda Equina, collection of the lumbosacral roots in the lower parts of the spinal canal. Epiconus, 4 segments of the spinal cord above the conus medullaris, L4-5, S1-2. Conus medullaris, the lowermost 3 segments of the spinal cord, S3, 4, and 5. Cauda Equina lesion, etiology, traumatic inflammatory neoplastic degenerative lumbar spondylosis, neoplastic, primary osteosarcoma or secondary metastasis, inflammatory TB of the spine, Pott's disease, traumatic disc prolapse, fracture or fracture dislocation of the lumbar vertebrae. Clinical picture, motor manifestations, sensory manifestations, and autonomic manifestations. Motor manifestations, paralysis or weakness of the lower motor neuron nature in the lower limb, in one or both lower limbs. The distribution of weakness depends on the affected roots. The affection is usually unilateral, but if bilateral, it's asymmetrical. Sensory manifestations, early, radicular pain in the distribution of the femoral or sciatic nerves. Late, radicular sensory loss in the distribution depending on the affected roots. The affection is usually unilateral, but if bilateral, it's asymmetrical. Autonomic manifestations, sphincteric manifestations, they are in the form of sensory atonic, motor atonic, bladder, and finally autonomic bladder with trophic changes. Distribution of motor affection, L2, flexion of the hip, iliopsoas muscle. L3, extension of the knee, quadriceps. L4, dorsiflexion of the ankle, anterior tibial group. L5, dorsiflexion of the toes, anterior tibial group. S1, plantar flexion of ankle and toes, calf muscles. S2, flexion of the knee, hamstrings. S3, 4, and 5, anal contraction, anal and perianal muscles. Distribution of sensory affection, L1, upper third of the front of the thigh, L2, middle third, L3, lower third of the front of the thigh, L4, anterolateral aspect of the thigh, anteromedial aspect of the leg, medial aspect of the dorsum of the foot with the big toe, L5, middle third of the dorsum of the foot, middle 3 toes, and lateral aspect of the thigh, S1, posterolateral aspect of the thigh and the leg, lateral third of the dorsum of the foot with the little toe, S2, posterior aspect of the thigh, leg, and foot. S3, 4, and 5, saddle area, anal, perianal, and gluteal region. Conus medullaris lesion, causes of intramedullary compression leads to its occurrence. Clinical picture, no motor or sensory affection in the lower limbs. Sensory loss in the saddle area, usually of dissociated nature, impotence, and finally, early urinary incontinence, autonomic bladder, plus stool incontinence. Epiconus lesion, etiology, causes of intramedullary compression. Clinical picture, motor, sensory, autonomic perceptancy of urine, sensory loss in the dermatome supplied by L4 and 5, S1 and 2, usually in a dissociated nature, and finally motor paralysis or weakness in the lower limbs of lower motor neuron nature and in the muscles supplied by L4 and 5 and S1 and 2. Flaccid paralysis, etiology, flaccid paraplegia, etiology, epiconus lesion at the anterior horn cells of the lumbosacral region, Cauda Equina lesion at the roots of the lumbosacral region, peripheral nerve lesion, neuromuscular junction lesion, muscle lesion, shock stage of the spastic paraplegia, diagnosis, clinical, lower limb paralysis of lower motor neuron nature, anatomical and etiological. Spondylosis, definition, gradual progressive degeneration of the intervertebral discs, especially those which are freely mobile, as they are more subjected to wear and tear processes. The freely mobile discs are mainly found in the cervical and lumbar regions. Predisposing factors, old age, occupational, diabetes mellitus. Pathology, the intervertebral disc is formed of nucleus pulposus, central gelatinous part, surrounded by fibrous tissue ring called annulus fibrosus. Disc degeneration, there is degeneration of the annulus fibrosus leading to herniation of the nucleus pulposus, leading to compression of the adjacent structures. Since the weakest parts of the annulus fibrosus are the lateral and posterior parts, the herniation will be lateral or posterior or posterolateral. Associated degeneration, sclerosis of the adjacent structures of the vertebrae, lipping and ossified formation due to calcification of the prolapsed parts and ligaments. Clinical picture of cervical spondylosis. We have Hoffman sign and Lermit sign. Hoffman sign, reflex contraction of the thumb and index after nipping of the middle finger. Lermit sign, electric-like sensation felt in the back and limbs on bending the neck due to posterior column affection in the cervical region. Presentations, any one of the 3 following manifestations depending on the direction of the prolapse of the disc. Features of root compression, lateral prolapse, we have anterior root compression, posterior root compression. Anterior root compression, lower motor neuron paralysis or weakness in the muscles supplied by the compressed roots. Posterior root compression, early and late, early pain and paresthesia due to posterior root irritation, which are referred to shoulder and upper limbs, brachial neuralgia. Late, hypothesia in the dermatomes supplied by the compressed root. And finally, features of cord compression, posterior prolapse, compression of the pyramidal tracts, compression of the spinothalamic tracts, and compression of the posterior column. For the posterior column, deep sensory loss, sensory ataxia below the level of compression. For the spinothalamic tracts, superficial sensory loss below the level of compression. And for the pyramidal tracts, bladder disturbances, rare and late, occurring in severe lesions, weakness and paralysis with signs of upper motor neuron lesion below the level of compression, features of root and cord compression, posterolateral prolapse in upper limbs, combined signs of lower motor neuron lesion in the form of wasting of muscles, plus signs of upper motor neuron lesions in the form of hypertonia, hyperreflexia, and this condition is called tonic atrophy. In lower limbs, weakness with signs of upper motor neuron lesions. Clinical picture of lumbar spondylosis present with the same picture of Cauda Equina. Investigations, MRI and CT. MRI is the imaging of choice. It detects small disc prolapse missed by other methods of imaging. Myelography, anterior filling defect due to disc protrusion and compression of the cord. Plain X-ray, straightening of the spines, loss of lordosis, lipping, osteophyte formation, sclerosis of the adjacent structures of the vertebrae, and narrowing of the intervertebral disc spaces. Treatment, medical, analgesics, muscle relaxants, physiotherapy, shortwave therapy, plastic neck collar, traction of the vertebrae, maximum duration of 3 months to avoid muscle fibrosis, surgical. Indications are failure of medical treatment, bladder disturbances, rare and late, occurring in severe lesions, sensory or motor affection, and finally, severe intolerable pain. Sciatica, definition, radicular pain along the distribution of the sciatic nerve L4 and 5, S1, 2, and 3, along the back of the thigh, leg, and foot. Etiology, spinal canal in the intervertebral foramina, in the pelvis, in the sciatic nerve, and referred. In the spinal canal at the lumbosacral regions, acute lumbar disc prolapse, lumbar spondylosis, fracture or dislocation, Pott's disease or tumors. In the intervertebral foramina, radiculitis or neurofibroma. In the pelvis, compression of the sciatic plexus over the sacroiliac joint by malignant tumors, bladder, rectum, ovaries, pelvic abscess, and pregnant retroverted uterus. Then we have in the sciatic nerve, neuritis as diabetic and alcoholic, pressure on the nerve by dislocated head of femur, wrong injection into the nerve. Referred, sciatic pain secondary to hip or sacroiliac joint disease. The most common causes of sciatica are acute disc prolapse and lumbar spondylosis. Acute disc prolapse, sudden rupture of the annulus fibrosus followed by bulging or herniation of the nucleus pulposus. This compresses the spinal roots. This may occur at any age. Following trauma or lifting heavy objects, plain X-ray of the back, narrowing of the intervertebral spaces without degenerative changes. So, to compare between acute disc prolapse and lumbar spondylosis, acute disc prolapse at any age, spondylosis middle age or old age, causes traumatic in acute, degenerative in spondylosis, onset acute in acute, gradual in the spondylosis, X-ray, narrowed intervertebral space for the acute, and for lumbar spondylosis, narrowed intervertebral space with sclerosis, lipping, and osteophytes. Clinical picture of sciatica, pain and paresthesia along the course of the sciatic nerve, aggravated by walking, which stretched the nerves, and coughing, straining, or sneezing. Pain relieved by bed rest on hard mattress in cases of disc lesions. Signs, sensory, tenderness and discomfort on direct pressure on the sciatic nerve. Motor, slight lower motor neuron weakness in the muscles supplied by the nerve, and ankle reflex may be weak or lost. Back signs, paravertebral muscles are spastic, resulting in loss of lumbar lordosis, tenderness, and limitation of movements of the spine. Positive Kernick, Lassigo, and Prudensky signs. Investigations, in cases with suspected lesion of the spinal canal, plain X-ray, myelography, CT scan, MRI, rectal and vaginal examination, plain X-ray of the hip joint, and finally urine analysis and blood sugar curve. Treatment of the cause, in cases of disc prolapse, bed rest on hard mattress for 2 to 3 weeks, analgesics, NSAIDs, and muscle relaxants to relieve the pain. Physiotherapy or decompression laminectomy when there is failure of medical treatment, frequent recurrence of pain, development of neurological deficit, whether sensory or motor. And this concludes our part for today.